Assalamu alaikum. Thank you very much, the organizing committee of the Shalamar Symposium, for letting me share our experience of pancreaticoduodenectomy at Lahore General Hospital. So I'm going to share our 5 years experience at Lahore General Hospitals and the lessons we learned. These are the objectives. So I'll discuss initially the historical development and some modern developments in pancreaticoduodenectomy. And then lastly, what are the lessons we learned within five years? So pancreaticoduodenectomy, or the other name is Whipple procedure, is done for many benign and malignant conditions around the periumbula. And the problem is it's a very complex surgery, and almost 60% of patients will have some sort of complications. And the majority and the major complications like hemorrhage and postoperative pancreatic fistula or intra-abdominal collections are responsible for a very high mortality, which was initially about 20 to 30%. And because of developments, it has gone down to less than 2% in high volume centers. And nowadays we're having minimum invasive surgeries like laparoscopic and robotic surgery and more aggressive operative techniques, which has basically improved the morbidity and mortality of this surgery. Well, let's go to the historical development of pancreaticoduodenectomy. It starts with this Italian surgeon called Via, who in late 19th century did the first operation on duodenum and pancreas. It was not noticed. This German surgeon, Walter Koch, basically was the one who did it another time, and the patient survived for a few days. But the credit goes to this United States surgeon, Alan Whipple, who initially in 1935 did a two-stage operation, and then completed in 1941 into a one-stage operation. And initially, he didn't do any pancreaticoduodenostomy or any pancreatoenteric anastomosis, but lately he started doing pancreaticoduodenostomy, and he published his series of major cases of Whipple operations in 1963, where he shared his experience, and which is a landmark paper for everyone to read. And this is the original description of his surgery. So from 1941, there are many modern developments, and now the Whipple operation, which is famous because of Whipple, has turned into a very different operation. And the first thing is that we have better understanding of the biology, especially the periumbral tumors for which this operations. We have less recurrence because of the availability of better chemotherapy, and as well as understanding that the concept of mesopancreas, that recurrence can be decreased if we take the mesopancreas as we do it in the mesorectum. And obviously we have better adjuvant treatments and better techniques, energy devices and hemostasis are available, which has become made this surgery very safe. And lately, the American contribution has continued. This technique has further developed in memorial stroke technique by Murray Brennan, in Johns Hopkins by David Cameron, Andrew Warshaw and Keith Littlemore in MGH, and Matthew Cares in MD Anderson. But this last guy, the Doug Evans, we invited this guy in the last surgical oncology conference, has made a tremendous improvement in the new concept of neoadjuvant treatment in resectable pancreatic cancer, and thus increasing the survival from 20% to 30% specifically for pancreatic cancer. But I will give credit to this German surgeon, Marcus Buschler from Heidelberg. And this has even further revolutionized. So we used to think that the arterial involvement was a contraindication. But in those patients who had no distant mets and even their arterial environments after neoadjuvant treatment, he showed that even you can do resection of the arteries and the vessels, as well as If you clear this triangular area, which lies between the celiac and the SMA and the portal vein, this triangle area, if you clear, majority of recurrences happen here, and this leads to, although a little improved mobility, but better mortality and survival. So now we have jumped into the era of minimal invasive, and we invited this Plani Vilo last year surgical oncology conference, and he has now more than 1,000 minimal invasive pancreaticoduodenectomy, both laparoscopic and Whipple. But there's a latest meta-analysis. It is still not the standard of care laparoscopic because of the complexity and the time taken by the surgery. And recently, we have seen the publication of first 500 cases of robotic pancreaticoduodenectomy. So the Whipple operation has become revolutionized from big open surgeries to minimally invasive surgery and better outcome. So I'm going to share our technique of doing a Whipple operation or pancreaticoduodenectomy. So we do it in 10 stages. The first is a staging laparoscopy, and if the laparoscopy is not available, the laparotomy initially done to see with a subcostal incision or a midline just to see if any evidence of peritoneal liver mets, which made it impossible. Pre-operative CT scans presently has led us to not to abandon any operation. We know that's irresectable beforehand, so we didn't have to abandon any operation just because we didn't know that this patient had a resectable tumor. The second step is opening up the Lessonsn through gastrocolic omentum, and now we have this nudgy devices. This makes it so easy. Then we do an extended cochlear maneuver, or sometimes get L-brush just to lift the whole of the right colon up to the SMB. Then the fourth step is doing a dissection of the portal apparatus, and that includes cholecystectomy and division of the common hepatic duct and the gastroduodenal artery and the right gastric artery, and all the lymph nodes in this area are taken up as a single portion. Then after that, we divide in a classical Whipple, we divide the gastric antrum, and then the jejunum is divided about approximately a foot away from the DJ flexure. And after this mesentery is divided, this is flipped behind the SMB and SMA. And the seventh step is the transection of pancreas and the section of the mesopancreas, which is very, very important. And step 9 is once you have done the resection, then we do a pancreaticoduodenostomy. And step 9 is a hepatocoduodenostomy, and the step 10 is gastroduodenostomy. And I'm going to share some of the pictures. So this is our step 2. After staging laparoscopy, we'll open up the gastrocolic omentum. And once you do gastrocolic omentum, the advantage of it is now you already have mobilized, open up the gastrocolic omentum and the Lessonsn. Now, as a second step, when you do this extended cauterization, in which you should be able to see the left renal vein over the aorta, this makes the job of dissection around this area quite visible. And then the next step is a portal, petaportal dissection, and this we identify the common hepatic artery and ligate the right gastric as well as the gastroduodenal doubly. And then we start cholecystectomy and all the lymph node dissection so that we can see the portal vein, because the idea is to make sure that the portal vein is clear. And then we do this antral resection, the stomach. The antral dissection, now you can see that the pancreas head is clearly visible along with mesenteric vessel. Then the sixth step is that we do a transection of the jejunum, and this jejunum is then moved towards the right of the mesenteric vessels for the preparation of the next step, which is a pancreatic resection. Now, this is a very important step because most of the bleeding happens around it, and most of the injury to the portal vein happens around it. So first of all, we need to basically ligate the tributaries of the superior mesenteric vein draining into the uncinate process. And mind you that you have to be very vigilant about the first jejunal vein because it curls around the artery and it comes behind the vein, and that's why sometimes it's injury. If you see it in the CT scan before and you are particularly aware of that problem. And then if you see this inferior pancreaticoduodenal, we make sure that the inferior pancreaticoduodenal, because after gastroduodenal, inferior pancreaticoduodenal artery is the second cause of intraoperative hemorrhage and sometimes the reactionary hemorrhage, which we see quite often in such patients. But this is like talking about this first jejunal branch, and if this jejunal branch, you see that it drains and goes behind the SMV and behind the SMA, and if it bleeds, it retracts and causes a lot of problems. So it should not be taken. Only if it is involved, then you can take it, but otherwise, so you have to be very, very careful about this vessel. The idea of all this is the section which should clear this triangular area. So this triangular area, this is the celiac trunk, this is the SMA, and this is the base is you see the this inferior vena cava. So this common hepatic artery, right? The other border is SMA, and the third border is this portal vein. All this area, which is a cause of recurrence, should be cleared, and this is a triangular operation, and we try to achieve that in all patients. When the reconstruction is done in usual manner, first of all, the pancreaticoduodenectomy, and we use the Blomgart technique, but in few of the patients, we have done pancreaticogastroscopy, and we try to leave a space, and usually this falciform ligament is incorporated in few of the patients in front of the this gastroduodenal artery just to prevent the blowout. This goes behind the jejunum, but in front of it, so just to prevent the blowout. And then we do an anticolic gastrojejunoscopy in such patient. This is a clip. Now, my 80% of my senior registrars, so one of my senior registrars doing this operation of material layer of Blomgart pancreaticoduodenectomy, and I take pride in this that all of my faculty members and all my senior registrars, barring one or two, been able to do it independently, even without my supervision. This is I take a pride in. These are a few specimens. And I think one of the important issues is grading of the specimen. This tells you that about the adequacy of your surgery. So in the last 5 years, our experience at LGH, we have operated about 95 and we've celebrated Wednesday 100. And the majority of them are males. And we have maintained a cloud-based tumor registry in which all the patient's data is available. And these have come from different corners of the province. And the yearly volume, this is an important slide to see, but when I joined in the first year, we had only 5 cases. And then we have a jump in the last 1 year. We have maintained a volume of above 15. And for somebody to have a high volume definition, you have to have 15 and above cases. And its majority is about 40 to 50s age, and majority of periampular tumors. Now, the complications we had, the dreadful complications, intraoperative portal vein injuries, and these patients come to that injuries later on in the ICU. But we have 3 bleeding, and that bleeding led these patients to be re-explored, and then few of the patient also had bile leaks or pancreatic leaks needing re-exploration. We have a mortality of about 10 patients. The mortality from 2017 to 2020 is about 10%. The last 1 year mortality is dropped to only 1 case, so we have about 6.6%. The majority of them, the cause of death is bleeding, and in other patients, it is pancreatic fistula. So bleeding has been important cause of death in our patients. Majority of patients are adenocarcinoma of the pancreas. So this is different from the Shalamar experience a few years back they shared, and because their majority of the patients were very ambulatory, and we had this pancreas as our major. And there are a few other cases, I think 8 or 9 benign causes also. So we have a follow from 1 week to 4 years, and majority 50% all alive. 10 died because of the postoperative complications, and 15 of them they've already dead in the 4-year follow-up. They are dead because of their disease, and about 20 are lost to follow-up because even we have their phone numbers, we've been available. So what are the key lessons or questions we are going to ask and select? So how did we achieve large volume? We achieve large volume because of higher referral from enroll. Once you develop repetition that you are doing a sales job, people send you. And because of a very good dedicated hepatobiliary pancreatic services in our GI gastroenterology unit. The mortality initially were 10%, but with the experience, learning, and I think developing a good team, our mortality has dropped down. And majority of my surgeons who young surgeons who assisted me initially, they have assisted in quite a number of cases before they're given cases in steps, and now ultimately for the last 1 year they're all doing independently. And our preferred technique is pancreaticoduodenectomy, although we have done pancreatic hysterectomy in a few cases. So this is a summary of all the lessons we have learned. We have selected the patients, so none application were abundant because of irresectability, and the cases was majority of them were discussed in multidisciplinary. ERCP and stenting for bilirubin, anybody above bilirubin, this is our strict criteria. Then we have the availability of Thompson restrictor that makes our job easy. We have all the energy devices and bipolars, and I suggest everyone who is doing and working on this complex surgery to basically have this available. Then we have adequately learned the lymph node dissection concept with triangular operation, and that's the reason we have a very low number of recurrence. And in some cases, we also did an artery first approach where we had some impression that the artery might have been involved. Then we have been doing standardized Blumgart technique, and we don't have any problem with that. Although we have tried pancreatic hysterectomy, some soft pancreas, but majority of patients since are stented, there's some sort of inflammation, and that's why they have dilated pancreatic duct and hard pancreas. The most important thing that we always operate in 2 teams. So one team for resection, the other team for reconstruction. And I advise all of you to basically follow this because if you are, you should be very well rested for reconstruction. And if you are operating very meticulously and spend 3 hours in resection, then probably your hands will be trembling, and the fresh team should be doing this better job. Then lastly, we have vigilance and monitoring for early detection of complication, and you usually do these CRP levels and drain amylase levels initially on the day 1, just to see which way your patient is going. And lastly, we have achieved ultimately a high volume center due to better availability of in-wall reference and our better unit. So I thank you very much for your kind attention. And if there is any questions,